Consultant surgical oncologist, Dr. K. Karthikesh. He is going to talk about the advances in oncology, and he is one of the pillars of surgical oncology in Sri Ramakrishna Hospital, the well-known surgical oncologist in the city of Coimbatore. And he is going to talk about advances in oncology. Yeah, the speaker is senior consultant in nuclear medicine at Ramakrishna Hospital, Coimbatore, and he is going to talk about the nuclear medicine molecules at work. So I invite both the speakers, and I thank them on behalf of the management for accepting our invitation to come and talk to the audience for the benefit of all the doctors. Thank you, Dr. Karthikesh, and thank you, Dr. Nageshwar Raj. First, I invite Dr. K. Karthikesh to take over the webinar. Thank you.
Good afternoon, everyone. It's an honor and pleasure for me to be amongst you all. I thank SNR and Strategic Trust, thank the IMA, and every one of you have come, spent your valuable time, especially a Saturday weekend, and everybody in election mode, for sparing such a valuable time and for being with us today and gracing the occasion. Thank you. Thank you, Sukumar sir, for doing this nice, wonderful introduction. I thank you very much, and for support all you have been throughout my career and in Ramakrishna Hospital. So this advances in oncology, it may not be holistic. I might have missed some few advances. Please remain. So I stand corrected if I miss something. So I hope it will be useful and it will be somewhat, it will cover almost everything. So still advances are yet to come. It will be happening all the while. And as somebody says, as a proverb says, change is the only constant thing that is happening in the world. So start with, I'll say with this quote: of the so many lakhs of species in the earth, living in the earth, only one species doesn't live in concordance or doesn't live in harmony with nature, and that is we human beings. Not a pessimistic note, it's a realistic note. Because we don't live in harmony with nature, the nature gives back us a lot of diseases. So we are now again trying to overcome all these diseases with many things, and one such thing is the advances in many things. So what we call a civilization or a sophistication or advances, they usually will have two sides. When it comes new, we see only the good side of it. Only when we experience the good side and we experience the bad side, we find the difficulties, then only we understand the bad side of the advances, and then we go for reparative measures. Simple example is the plastic. It was so convenient, but only after using it and experiencing so many difficulties and realizing that it will cause so many diseases, now we think that plastic is a hazardous and it's a problem. But now we have come a long way, very difficult to rewind and go back. Same in everything, whether it be a mobile phone or a vehicle or electricity or electronics or whatever it is. So the advances is like a double-edged weapon. It's like we should take every advance with a pinch of salt. But for the betterment of mankind and benefit of everybody, we need to have advances. So we cannot. So we have to balance it and go ahead. This slide is this level of prevention is important for every disease, not necessarily only for oncology. It's important for every disease. So that's why I put this slide as first, because advances happen at every stage. For example, the primordial prevention, that is where primordial prevention means you avoid or prevent the development of risk factor. Then there is primary prevention. The risk factor is present. You either treat or remove the risk factor before the onset of disease. Then comes the Secondary prevention, where the disease has already started, but is still in the asymptomatic stage. So that would be early diagnosis and treatment. That would be secondary prevention. And finally, the tertiary prevention will be reducing the complications, that is disability limitation and rehabilitation. That will be a tertiary prevention. So for any disease, it's better to be in the stage of primordial or primary prevention. That would be the best time to treat any disease. So it's better to, as the old adage says, prevention is always better than cure. So what is primordial prevention? That is, we prevent the onset of risk factors, prevent the risk factors from acting or avoiding a risk factor. The best simple primordial prevention would be an exercise to prevent obesity. You know, obesity causes so many diseases. So a simple primordial prevention, an exercise to prevent obesity. Obesity is a risk factor. Before the obesity comes in, you do exercise, perform exercise, keep yourself healthy. That is a primordial prevention. So, as far as the medical fraternity is concerned, vaccine is an important example of primordial prevention. The various awareness campaigns that goes on, especially nowadays with the well knowledgeable people and also the with the social media, the awareness campaign. There's a lot to do. The legislations which the government and brings in and the people self-discipline, all these things, the legislation like the anti-tobacco law, prevention of food alteration, the pollution control, all these are primordial prevention to prevent the onset of or prevent the risk factors. Next is lifestyle modification that comes from us. So we also should realize and take it from there. So the examples of primordial prevention, the latest, I won't say it is advanced. I would say it's very important. It will be there for almost forever. It will be a time tested this thing. For example, is the vaccine to prevent cervical cancer. That is it. The vaccine against human papilloma virus that prevents cervical cancer, because more than 90% of cervical cancer are associated with either the HPV 16 type 16 or 18. The other, so we have two vaccines in that. That is the bivalent vaccine that against 16 and 18. The quadrivalent will have the pre-malignant Wart against the 6 and 11 also. So vaccine is an important factor and example of primordial prevention. It has gone a long way. I would say that cervix is almost nearly reaching the time of elimination, cervical cancer. So as I said earlier, any law against smoking, nowadays we see less and less people smoking in the public because good enforcement of that is ban of smoking in public. There is no ban on smoking, but in public it should not be nobody should smoke. And so that is a good example of primordial prevention. Next one is important one is the hepatitis B vaccine, which has been there for quite some time. It's not an advance. And that is definitely helps in preventing the hepatic cancer. As I told earlier, the exercise has a very important because it improves the immunity, reduces the fat, and thereby reduces a lot of diseases apart from cancer. So exercise is very much essential for the general well-being and not to prevent cancer alone. So just to indicate what are the malignancies that are associated with obesity and how exercise would help in preventing them. So most common one would be the endometrial, colorectal, and pancreatic. The others, of course, would be probably less associated would be kidney, gallbladder, esophageal. Of course, breast has a strong association with obesity. Again, lifestyle modifications. Now only people gradually realize the ill effects of what we call as advancement, like in the form of having a French fries or a pizza. These are all Western diet. The problem is we copy the West what should not be copied, and we don't copy what should be copied from the West. So that is the problem. Now we are gradually everybody is getting the awareness that all these can cause cancer in the long term. So these foods generally, especially though tasty, the children better to keep it away from the children and teach them about it. Now, coming to primary prevention, uh, here the risk factor is already there. That is primary prevention, but we treat or eliminate those risk factors. That is called primary prevention before the onset of disease. So, primary prevention is before the onset of disease, in the treat or eliminate the risk factors. Important in that would be the genetic screening, which is probably there for around 5 to 10 years now, and with the vast leaps and bounds of development in molecular oncology, molecular this thing, biotechnology. So the especially after uncoding the human genome project. So genetic screening is an important component in primary prevention. Next comes the prophylactic treatments to prevent a disease. Next will be the many tobacco cessation clinics and many more. And there are a lot of examples for primary prevention. So quite a number of genes have been found to be mutated in many number of malignancies. Of that, the most important would be the ones for the breast, that is the BRCA1 and the BRCA2, and then the colorectal, the DNA mismatch repair genes or the microsatellite instability causing genes, and then the APC gene, that is adenomatous polyposis coli gene, and BRCA1 is always they call it as the BRCA1, BRCA2. And next is the P53 gene that causes the leukemia and a variety of quite a number of many types of cancers. So usually the genes that are screened usually are the BRCA1, BRCA2, the DNA mismatch repair genes or the microsatellite MSA microsatellite instability genes, the APC gene, and some genes are not listed here. That would be the von Hippel-Lindau disease that causes by renal tumors, when the neurofibromatosis gene that causes the over a period of time, apart from neurofibromatosis, they can transform to neurofibrosarcomas. The best prevention and the most well known is the BRCA gene test and the prophylactic mastectomy, where only when the celebrities undergo major procedure, we all realize the importance and we all come to know about it. Otherwise, it's always usually a low-key affair, nobody knows about it, and nobody even bothers to look at it. Once the celebrity does it, everybody looks at it, becomes a high affair, and then everybody starts practicing it. See, so that's what happened with Angelina Jolie because she had a BRCA1 mutation. She has undergone bilateral prophylactic mastectomy, that is before the onset of breast cancer. This is our patient whom we would have operated around 15 years back. Patient, if you see, there are multiple sebaceous cysts in the back, a strong family history. At that point of time, we didn't have here in Ramakrishna in Coimbatore, we didn't have any test for genetic screening, and it was costly, so we didn't follow up with genetic test. But there is a strong family history of colonic cancer. His uncle had colonic cancer, his mother had colonic cancer, his sister had desmoid tumor, and he had a multiple sebaceous cyst with so many polyps in the colon. So it is strong, it's a familial adenomatous polyposis coli, and he was willing with the total proctocolectomy, and we did the total proctocolectomy, and to date he's even now he's fine. That thing, and he was not against the permanent ileostomy. He was happy with the permanent ileostomy, even though he is happy, and he was not for any pouch or any sphincter sparing procedure because he saw his uncle be having so many complications like pouchitis, fistula, and so many things. So he is now happy with the permanent ileostomy. Unfortunately, his sister had to expired because she had desmoid, but she didn't come for treatment. Next important primary prevention would be, which is a very, very, very essential for anybody. Would be anybody in the world would be this quitting tobacco, because 30% of cancers are attributed to the tobacco. So now, as an advance, if you see, we have so many apps that help you in quitting tobacco. So many apps are there. It keeps a count and it helps you. Sometimes it tells you something. So lot of apps around to quit tobacco. I would say that is an important advancement in social media as far as in primary prevention. And definitely the effect of tobacco lasts sometimes even up to 10 to 20 years, and tobacco has around about thousands of carcinogens in itself. So it's not just the carcinogen alone, it causes neuromuscular diseases, cardiovascular diseases, and many more. Now, coming on to secondary prevention, where the disease has already started, but still in the asymptomatic stage. So that's what so when we apply tests on asymptomatic individuals, then that is called screening. But the contrast is the genetic screening, where the disease has not started and still in the presence of risk factor, we are applying a test. That is, genetic screening is an example of primary prevention, though it is called screening. So generally screening is mentioned as referred as method of secondary prevention. But here in this situation, genetic screening starts before the onset of disease. So it is, though it is called screening, it is primary prevention. So early diagnosis and treatment is early diagnosis is the part of screening, various screening campaigns which the medical fraternity tries to perform. So mammogram, pap smear, CT test for high risk smokers, and fecal occult blood test. The FOBT is fecal occult blood test, and the scope is which we perform for colorectal cancer, prostate specific antigen, and digital rectal examination for prostate cancer. So all these are screening procedures that are attempt to for early diagnosis. But again, this happens only after detect only after the onset of disease, but the patients are asymptomatic. So one example of advance in the early diagnosis would be the would mean machine learning. That is application of artificial intelligence in radiology. It is going on in all fields of medicine, not only radiology. It is going on in the malignancy. It is even whether they are trying to evaluate whether the artificial intelligence software can operate the robotic arms of the surgery. Though they have not done it on patients, they have done it on specimens and like suturing on a paper or a models. So where they found even the AI software were able to suture as equivalent as the human beings. So the research is going on. So machine learning, what happens is they feed all the computers, the software with all the pictures, like what would be the malignant features, what are the benign features. They feed thousands and millions of pictures, and with various techniques they learn themselves. The machine, that's called machine learning with artificial intelligence. And then they found out that there's definitely they can perform at least as good as the human this thing, and many times they have proven they have overcome the human errors also, and they are diagnosed it better than sin. That's what there is a 10% improvement in specificity of performance. All these are FDA approved. At present, there are 29 artificial intelligence software that has been already approved by the FDA and is in current use for practical regular use of software after 29 artificial intelligence softwares in mammography as well as radiology. So though it has made this thing easy for the radiologist, sometimes I wonder whether are we trying to de-skill ourselves, we lose our skill. So that was one important advancement in mammography or radiology, where they would be able to interpret they would interpret or estimate the risk of development of malignancy in their mammogram as well as this thing. Mammogram, what they tried, there are quite a number of trials which showed that where they serially fed the mammogram pictures and the AI artificial intelligence software estimates the risk of malignancy. One such is the slide which I showed earlier, where this lady, she deals with the researcher in machine learning in languages. But when her mammogram was fed for three consecutive years, none of them doctors mentioned any estimated risk of cancer. But finally, she developed a malignancy. But when retrospectively, she herself, out of interest, fed all the mammogram pictures onto the AI software, it estimated that she might have ran the risk of developing 98% of cancer. Of course, she developed cancer and she has been treated and doing fine. So already there is artificial into machine learning and artificial learning intelligence already there in mammography and radiology. Next is the various different methods of mammogram. That is the full field digital mammography, the low energy contrast enhanced spectral mammography, and then this where we combined images, where we reconstitute images which show all to increase the specificity and sensitivity. Again, tomosynthesis, that is a different method. That is another current method that is being used again to improve the sensitivity and the accuracy of, especially the sensitivity of mammogram, where the lesion which has been missed on the digital mammogram has been picked up by tomosynthesis. Tomosynthesis is the moving way it takes in the form of sections and then reconstitutes the section. Coming to pap smear, which is another important tool in preventing cervical cancer. Again, here I would say it's the liquid biopsy test. So what happens here is the cell samples are not scraped onto the slide. Instead, it's collected into a container with this fixative, and then they centrifuge, process it, and then spray it on the slide. That way, we can have a prevention of the clumping and overlapping of cells, and then so it won't obscure. So liquid-based cytology again is a form of pap smear with better sensitivity and accuracy. Then this is the processing of the smear. This is on the right. This is example of the pap smear where we can see the clumping and overlapping. This is an example of the liquid-based cytology where the pathologist will be able to read it better. Next would be the PET scan. My friend Dr. Nageshwara is going to deal with it, so I am not going to go in detail. It's one of the recent advances and definitely it's a boon. Apart from accurate staging, definitely helps us in quite a number of times we were able to diagnose a second malignancy with the PET scan, which we would have ordinarily missed with the routine X-ray test or a CT scan or ultrasound abdomen. And again, the advancement in PET would be the time of flight. The time of flight PET, that is, it uses the activation of the sensor from the patient, that is from the emitted 18-fluorodeoxyglucose emits the photon. From that, it reaches the sensor. That time is calculated, and so it's used for better spatial resolution. So definitely, thereby improving the sensitivity and accuracy. Next would be the light microscopy, which has stood the test of time and definitely would be there forever. But nowadays, with the advances, with other advances, what happens is light microscopy alone would not be sufficient because quite a number of tumors and conditions mimic each other, and so the treatment for each thing would be different. So to differentiate that, now we have all these things, that is the fluorescent in situ hybridization, the immunohistochemistry, and the karyotyping. So to differentiate the mimics, that conditions that mimic each other, we need all these adjuncts. So quite a number of times we have treated lymphoma as melanoma, melanoma as lymphoma, and that is because we treat only with, sometimes when you treat only with microscopy, that can happen. So now to prevent all these things, now the pathologists, they have also become more defensive. So though they can very well see the diagnosis with light microscopy, now they're more into immunohistochemistry. So these are all the other advancements which are coming in a big way, which are already well established, I would say, beyond light microscope. Next, everybody is now more familiar with the polymerase chain reaction, which has been there even before the advent of corona pandemic. So polymerase chain reaction, where with a small DNA we can replicate, multiply, and we can make multiple copies and then find out exactly what it is. Again, the artificial intelligence is gradually picking up, wherein again in pathology, machine learning has proven to be useful and it is matched or even performed better in typing many number of tumors in pathology. So that's what they train the artificial intelligence software with what is normal and what is tumor, and they use various techniques, which is beyond the scope of medical fraternity, and then finally they arrive at this thing, and they have proven that it is equivalent to or better than the interpretation given by the pathologist. Next important advances is the liquid biopsy, which means that it is not there. We just it's not we need not always go hunt for the tissue sample. We capitalizes on the tumor material that is present in either the blood, urine, or the sputum. So it is a very non-invasive technique. Why sometimes the whole cells might be present, or sometimes the DNA might be present, or sometimes the tumors markers might be present. So it makes a very less invasive procedure, but it's not that easy as it is appears to be. Here we can see the advantage, and this is non-invasive, early detection, easily detectable, and a personalized therapy because we get the DNA. But the problem is heterogeneity of tumor. Many tumors may again mimic, and many may not show up, complex variants, and some tumors may not shed the tumor, or may not be any circulating tumor cells, and again the bias will be there from this thing. So again, this is evolution, but definitely this would catch up one day. And coming to treatment, being a surgeon, I would see how this is in BC. Now, this is the current state we are in. There is a robotic surgeon where a surgeon doesn't even wash or make render himself sterile, and he doesn't even touch the patient, but yet he operates. So that is the state we are in, and still it is progressing. There are again many. The current concept is precision, minimal invasion, the same time no compromise in the oncologic principles or cure. So that would take the first thing to, for want of minimal intervention and for precision, we should not compromise on the oncologic principles and cure. But in the process, there is the minimally invasive or minimal invasive procedures are also still evolving, I would say, though it is well established over a period of time. We do come across some patients who probably would have done better with an open surgery also, because sometimes that sort of dissemination that we rarely have seen with that sort of dissemination we rarely would have seen with open surgeries. Sometimes it does happen, but over the trials, randomized control trials, and the statistics show that there is no difference between an experienced minimally invasive surgeon and an open surgery in many of the diseases. Though I'm not going to go by each and every disease, but generally it's coming, and for benign it is well established. For malignancy it is gradually in evaluation. Next is endoscopy. Now the medical gastroenterologists, they try to do everything endoscopically. So now they have this an example of endoscopic ultrasound. Here we can see the endoscope here, and that is the bile duct. We can see the mass in the pancreas. So and they try to do a biopsy also with that. So endoscopic ultrasound, it's all coming up. It's already there in practice. And again, endoscopic mucosal resections, where the Japanese are good at it. They resect only the mucosa, especially for the early gastric cancers. Next, the endoscopic submucosal resections. And finally, the endoscopic full thickness resections. This is all catching. Even our gastroenterologists have done a few cases. And next, less invasive procedure would be RF ablation, where we stick in a probe into the affected organ. For example, our interventional radiologist, Dr. Muthurajan, he has my relative. He had an intraoperative chronic 85-year-old with a chronic hepatic failure, who is not fit for, not a surgical candidate. And now 3 years since he did ablation with either radio frequency or microwave, and he is still doing fine. So that would be the this thing again with the image guidance. He puts the probe in, generates heat, deployed, and the tumor is destroyed. It's done in a single stage or multiple stage. As you can see here, direct tumoricidal effect, minimal systemic effects, less invasive than surgery, less expensive than surgery, and applicable to all non-surgical cases candidates. So this is also coming in big way, and we have a example. We have done it and performed it in lungs. We have performed it in kidneys, and we have performed it in liver also. So that's the current concept: precision surgery. So less is enough, not more. And again, this has stood the test of time. For a period of time, it has been proven that nowadays, we don't do mastectomy, breast conservation is possible. So again, in breast, again we need not remove the whole of the axillary. We not do a complete axillary dissection. Enough, we will trace the first sentinel node, the first node to drain a particular area, harvest it, look for frozen section, and then if necessary, complete the axillary dissection. Advanced diseases, malignant treatment being multimodal treatment, even if it is not operable, we can make it operable by instituting some neoadjuvant treatment. And tumors like this also can be made operable with neoadjuvant treatment. But that doesn't mean we can delay it or to this stage. It's always better to prevention is better than cure, and detecting it at the early stage definitely improves the results, survival results. This is a limb salvage surgery with the osteosarcoma of the femur. This is a post-chemotherapy neoadjuvant therapy. We have removed the femur and put a process, titanium process. Microvascular free flap reconstruction. This is already in use. Like this osteosarcoma of the mandible. You can see the slice of bone. That's the specimen, and that's the fibula harvested from his leg, and that's the reconstruction post-op. Next would be the radiotherapy. Again, lot of advances in radiotherapy. Important one would be the tomography, where the precision, again, as far as oncology is now concerned, the current concept is precision, at the same time without compromising on the outcomes. So here we can see the red one is the percentage of radiation dose. See, the prostate has got the maximum dose. Yellow would be the next. Yellow would be the 51% of dose. Then the cyan, and then the blue, where the decremental dose to the surrounding structures, so that the healthy tissues do not get the radiation dose and thereby prevent the side effects. For example, the comparison between the chemotherapy, intensive modulated radiotherapy, that is the current thing, and our managing trustee has generously sanctioned to get a third machine for LINAC, that is the for tomotherapy, for precision radiotherapy. I will thank him for it. And this is the old conventional 3D CDRT, where we can see the dose here, the anterior abdominal wall, the bladder, and this is for the esophagus, and we can see the maximum dose has come outside the esophagus also. And here intensity modulated radiotherapy is better than 3DRT. Here we can see modulate the dose of each beam, and that way the dose is confined, the hotspots are confined within the tumor. And tomotherapy, yes, the tumor alone gets the thing with minimal dose for the health, even better than IMRT. So again, radiation therapy, that is the precision treatment, and with so many advances, radiation also has become precise. And again, there is a software. Usually, all these are done with the help of a treatment software called the treatment planning system. They have each company has their own name for the treatment planning system, which is nothing but a software. Now again, they have incorporated the artificial intelligence into this treatment planning software, and again, it is this registration. This has been approved by the FDA, and it is in use. And it has. That's what this system creates high quality treatment plan within minutes, bypassing need for user intervention. Not so. The user always needs to be there. So the registration generates plan very quickly and a good quality plan. So so the plan is generated within 2 to 3 hours, whereas for if you do it manually, it takes around 2 to 3 days. And this is approved by the FDA, and it is in use actually. And again, coming to the therapy treatment, that is medical therapy. The first one would be the targeted therapy. That is, nowadays we use less and less of chemotherapy, so that to reduce the side effects and thereby, and this is a target specific therapy. We understand where the mutation is, whether it can be targeted. Mutation can be targeted with any drug. So that is imatinib. So it's I would say this is one of the earliest targeted therapy example of that is imatinib. It is revolutionary treatment of chronic myeloid leukemia and gastrointestinal stromal tumors. So this is roughly a concept of the personalized cancer therapy or targeted therapy. So the current chemotherapy, that is, we diagnose adenocarcinoma or ductal carcinoma of the breast. So So everybody, we treat everybody the same, but it's not so. Not all ductal carcinomas behave the same way. Each person, according to patient factors, the disease factors, and many other factors, behaves in a different way. But the treatment is the same for all of them. So that is the current treatment, whether it's colon or breast. So the therapy is the same. Some have effect, some have no effect, some have only adverse effect. So the trend is nowadays is to do a genetic profiling, molecular profiling, or genetic profiling from this. So segregate the patients target who will be amenable for which target. So which mutation will be amenable for which target, and then treat them accordingly, thereby with better effect. One simple example would be locally advanced gallbladder. In our experience, in my experience, it was deemed inoperable. We opened, closed it, and now the patient, after this molecular profiling, he was started on olaparib, and is now disease free for the 3 years. Absolutely all right, as if we can't recognize as if it's CA gallbladder, because CA gallbladder is one of the worst prognosis disease, and survival usually is over only a few months. And all this is possible because of this one particular thing is come now and now getting commercialized. It's already commercial and it's available now. That's the next generation sequencing. That is one type of molecular gene sequencing. So with this, they try to identify whether any targets are available for uh, targets, any mutations are available to target with specific drug, and finally they target it. So that's what is in the Sanger. That is what is how he this thing. He found out insulin that he used it in the lab manually. Now the whole genome is sequenced. It's not a small segment of or chain of DNA. The whole genome has been sequenced. It's very difficult to sequence the whole genome, but whatever is important is now can be sequenced. It is now commercially available and being targeted. Finally, would be the tertiary prevention and disability that which means disability limitation and rehabilitation. Like we have the bionic process, which and all the various also it's all evolving and still lot more to go. And this would be the our patients. This post laryngectomy tracheoesophageal puncture process where we can occlude this thing and speak. In spite of all these advances, we still do have patients come to us like this. That is because we have to compete with the alternative medicines like alternative medicines. So I always tell my juniors that India is one place where quackery is legalized and authorized. They resort to all these things and come to us when it is not curable. And I would like to add one more arm. It has to be balanced like a tripod. So we, the treating oncologists, have to balance between the increasing tumor incidence, the treatment advances, and the third arm would be the morbidity, and the fourth arm will be the cost. So it's not just a horizontal bar. It's like a crossbar, four arms. So we have to balance all these things and take into consideration all these things, and then treat the patient and give the best disease outcome. Let's hope. I hope I would be living up all to all your expectations and for finally the benefit of society and the patients. Thank you.
Thank you, Dr. Karthi. And I think it was a wonderful lecture. And questions, I think after Dr. Nageshwar finishes, we can have the question and answer session. Dr. Nagesh, you can.
Good evening, one and all. I'd like to thank SNR's Trust and Dean Director SRH for giving me this opportunity. And today, my talk will be about nuclear medicine because it's an unclear medicine to many of the doctors. What we do, what type of scans we do, what are the radioactivity we are using. So actually, the nuclear medicine is a branch of medicine which deals with the radioactive substance. We are mainly used in for diagnosis, treatment, and research. What is the main difference is it is doesn't difference between the ultrasound, CT scan, or MRI. Here they give the structural changes or what are all the size, etc. But looking at the functional aspect, we need to do a nuclear scan. So we basically it gives an information on changes that occurs at the cellular level. It's also called as functional imaging or bioimaging or molecular imaging. So the concept is totally reverse when we compare to radiology. That is, we make the patient radioactive. That is, we call it hot and then we visualize. So in X-ray, in radiology department, you can see CT or MRI where you have a machine which gives radiation. That radiation passes through the body and it gets filmed. So, but in our department, nuclear medicine, the reverse. We make the patient radioactivity. Once the patient becomes radioactive, the gamma rays are coming out from the patient, and these gamma rays are imaged using the detectors. And these gamma rays will help in producing the images. So these gamma rays, as I told you, everybody will be aware alpha, beta, and gamma. These gamma rays is mainly used for imaging. Then what about these alpha, beta? These alpha, beta are mainly used for nuclear therapy procedures. All the nuclear therapy procedures depends on this beta and alpha. So generally, alpha can be just stopped with the hand, and beta can be stopped with a thin piece of aluminium. But look at this gamma. Gamma can penetrate the aluminium, and only stopped by lead. So based on this energy of the gamma, the thickness of the lead varies. That's why you'll be seeing people wearing these lead aprons who are working in all the radiology department and radiotherapy departments. So basically, it is divided into two branches, mainly diagnostic and therapeutic. In diagnostic, we have two: SPECT, single photon emission computed tomography, are also called as gamma camera, and PET scan, positron emission tomography. And in therapy, we have high dose and low dose therapies where we have an isolation room, mainly for iodine therapy for thyroid, MIBG, for pheochromocytoma, strontium for bone pain palliation, and lutetium therapies. So coming to SPECT. This is the basic SPECT machine. You can see the two detectors, one at the above and one below, and you can see the patient couch here. The patient will be lying down in the couch, and this couch automatically moves inside out. So simultaneously we can image anterior and posteriorly. Initially there were only one detectors were there, so we make the patient to turn around, and then posterior imaging was done. Nowadays, simultaneously anterior and posterior images can be occurred, and moreover, this detectors will be able to rotate. So mainly for cardiac imaging, you can see this goes in for rotation. And recently now 3 detectors has come. 3 detectors means the patient will be spending less time in the machine. So main radioactive pharmaceutical which is used in gamma camera or SPECT is technetium-99 and iodine-131. So where we get it is, so technetium-99 is generally produced in-house. In-house means we have a molybdenum generator. Molybdenum is the mother and daughter product is technetium. So every time molybdenum decays into technetium-99, and every morning 24 hours time is needed. So every time morning we can elute this technetium from the molybdenum. And this is called, we call it as like milking of the cow. We tell it as milking the generator. And iodine generally it is not produced in anywhere except in nuclear reactors only it has been produced, and throughout India it is supplied by Baba Atomic Research Center from Mumbai. So looking at the half-life, you can see technetium-99 half-life is only 6 hours and then energy is only 140 keV. But if you see the iodine, the half-life is 1 week and the energy is very high, 364 keV. So that's why we every day morning we elute this technetium-99 and use for the scan. And if you see the half-life of iodine is 8 days. So every week we are getting this iodine from Baba Atomic Research Center, which can be used for a week. This is the photo of the generator where you have seen the 2 openings. One will be inside this will be the molybdenum which is studded inside, and it decays and gives, and the white dots will be like technetium. So just we put a saline inside, and other side we attach a vacuum vial. The saline goes, takes out all the technetium, and the vacuum vial gets filled with the technetium, which is in the liquid form. So this is our hot lab where you can see the generator and you can see the lead blocks which is used for shielding. So once we get the liquid technetium is produced in the lab, which is called as, we call it as radiopharmacy, and based on their appointments where we do like renal scan, thyroid scan or bone scan. So that is depending upon the cold kits. These cold kits are in the powdered form. These are all non-radioactive like DTPA, DMSA and MDP. What is the specialty of these cold kidneys? If you inject DTPA alone, it will go to the kidney. It doesn't go to any other organ. Same like MTP, it will go only to the bone. But you need to visualize that. How to visualize that? So you add technician. So you mix up. These hot and cold get mixed up. That is the radiopharmacy procedures. There are a lot of steps involved in that. The ones based on the patient, which are the patient needs for a bone scan. So technetium 99M is taken, MTP is mixed with it. So technetium 99 MTP is created and it is injected to the patient. If for a renal scan, same procedure for DTPA. So there are two types of imaging. One is delayed and dynamic imaging. Delayed imaging is you inject and wait for 2 to 3 hours for the background to get clear, then you image. But with dynamic imaging, it is done on the machine. Patient is made to lie down on the machine, you inject the isotope and you image it. So this is a picture of the bone scan, anterior and posterior simultaneously occurred, and this is a picture showing the thyroid. And this is the renal scan. You can renal scan. This is a dynamic imaging. You can see the image. First, you can see aorta is seen. Then you can see both the kidneys. And by the time goes, you can see the kidneys are not visualized. Slowly, you can see the bladder getting filled out. So this curve shows the activity which is entering the kidney, comes out, and then it is totally drained. By the end of the scan, there is no kidney. The whole scan gets completed within 20 minutes. So because of this, you can see the left side, you can see right side, you can see the column where you can see the GFR. The CT or an ultrasound will show, as I told you already, that will tell the measurement size of the kidneys or cyst is there. But what is the output? What is the functional status of the kidney? Like how much urine is produced in each kidney is shown only by the nuclear scans. So this is a DMSA scan which is done for scarring. And another thing, these donut scans or cardiac scans, which will be seen the normal anterior, septum, inferior wall, lateral wall, everything is seen. This is normal cardiac scan. Now coming to another modality, PET scan, positron emission tomography. So this, which is a non-invasive diagnostic imaging, mainly used for the for measure the metabolic activity of the cells which are in our body. So way back, it was developed in 1970 itself. So what is this positron? Why is this name called? Positron is nothing but an opposite of an electron. It is almost similar to electron, but it has an opposite charge. So it is always in an excited state. It was first postulated in 1928 by Paul Dirac. Then Anderson tried to name this electron positron as negatron, but he was unsuccessful. So this positron name still persists. So what happens is this positron is always in an excited state. Immediately once it enters into the body, it immediately reacts with an electron. So after that, it undergoes annihilation reaction. So converting all that mass is converted into energy. So this results in production of two gamma rays, like 511 keV. So yes, if you see in SPECT, what I told already, the technetium is only 140 keV and iodine is only 364. But you come into PET scan, you can see the energy of gamma rays is 511 keV. That is, indirectly it shows that more amount of radiation is coming out. So the more amount of radiation is given to the patients. And that is the one thing where the PET scan has not come into like screening or routine in mastical checkup. Why PET scan is not included? Because of this drawback. So mainly this positron emitting radionuclides are produced in-house also, and it is also mainly produced in cyclotron produced. The cyclotron produced is nothing, is like a medical cyclotron facility. We call it like MCF. It is like a factory where F18 is produced, and it is, you can see the half-life is only 110 minutes. And in-house generator produced is Gallium 68, which has half-life of 6 hours. So in our country, as of now, we get F18, FDG, PSMA, and DOPA scans. And in-house, we can able to produce Gallium 68, which we can go to PSMA and DOTA scans. So this is an image of the first PET scan way back, started in India in 2000 at the Tata Memorial Hospital, Mumbai. So concept is that both, it has CT part, which machine gives radiation, then the patient goes into the PET part. As I told you, in PET part, the patient radioactive, so PET image detectors will be there in the PET, which will get image, all the radiation coming out will be scrutinized in the detectors. So there are a lot of crystals are there and each company uses different types. So BGO crystal like GE PET scan uses BGO crystals. Siemens uses LSO crystals. Others are GSO, ISLO. These are all various detectors or crystals are there. So here if you come, what is this F18 FDG is the pharmaceutical we produce. And hardly I told you, this is 110 minutes. The main thing, the cost of the PET scan is a bit costly than compared to other scans because that is because of this half-life. For example, we in Coimbatore, we don't have this medical cyclotron facility, so we are depending from Chennai or Bangalore or Cochin for that. But if you see that by even you are using or not, the activity will go off, whether you use it or not. Suppose I have 10 patients, I need 100 millicurie here for my use. I need to order at most more than 1,000 like that. So whether you use it or not, it will get decayed. So when it's from the production side, they will dispatch 1,000 means it will become automatically 100 by travel. If we travel in 2 hours, another 2 hours it will another go. So example, if you think from Bangalore, by reaches Salem itself, 2 half-lives will be gone. Like 1,000 will become 200, 250 millicurie. Then from Salem to Coimbatore, another half-life will go up in 110 minutes. So ultimately I get only 100 to 110. But the hospital needs to pay for the 1,000 millicurie which we procured with them. So that is the reason PET scan is bit costly till now. So the concept is here the F18 is a radioactive material and FDG is a cold kit. So what happens is cancer cells uses more of glucose. So automatically FDG goes into the cancer cells, takes this FDG. So along with this FDG, F18 also goes. It undergoes, as I told you already, annihilation reaction. 511 energy gamma rays are emitted, that is get imaged. And the site of the cancer is clearly seen. So why deoxy? That is also one thing is there. Normally glucose, it's a GLUT1 receptors are there in cancer cells. These GLUT receptors, glucose enters and it goes into TCA cycle. But because of this deoxy component, fluorodeoxyglucose, it gets trapped inside the cell. So once this F18 FDG enters the cancer cell, it stays there. It doesn't go. So these are the things. Once the patient gets injected, it reacts with an positron is emitted. Positron combines with an electron. The two gamma rays are produced, and these gamma rays are detected by the array of the crystals, and you can localize the cancer cells. So this is a snapshot of our department, which during our construction is, as I told you, that the full radio protection is there. So we use lead or concrete can be also used, but concrete is thickness will be more. For example, 1 centimeter of lead, you need to convert. If you want it in concrete, you need to be like 5 centimeters. So based on if you have more space, we can go for concrete. Less space, we use lead. So this is a picture of medical cyclotron where F18 is produced. That is O18 is the water on proton bombardment gives F18. And once this F18 is produced, this F18 in liquid form comes to this dispenser. Here FDG is there, fluorodeoxyglucose. Now this F18 and FDG gets mixed here, and then it is transported to us. This is the in-house gallium generator which we have. Same, it is like same normal saline if you inject. The germanium, this is the kit is germanium. There we have molybdenum and technetium. Here we have germanium, which decays and gives like to gallium. So every day we inject elute and then inject accordingly. So this is our system where radiopharmacy depends on PSMA or DOTA. We do that. We mix up the concerned cold kit and then we do the scans. The main patient instructions, fasting is main. Why fasting is main? Because we need to make the cancer cells hungry so that we don't miss any lesions. So blood sugar should be always less than 150. For brain PET, there is no need for any fasting, but post injection we need to ask the patient to close the eyes, and then or else we make the room dim. Cardiac basic physiology is cardiac uses fatty acid metabolism and glucose metabolism. So overnight fasting is required. So once in overnight fasting means automatically myocardium will shift into fatty acid. So we need to simulate the fed state. That's why when the glucose, whatever glucose we give, it will get absorbed by the heart. So the imaging will be good. So based on that, we give glucose load and then followed by insulin. In non-diabetic, we give a glucose followed with 3 units of insulin. If it is a case of diabetic, if sugar is more than 150, just we give it with insulin. Now, why is this insulin is given is cardiac GLUT receptors are GLUT4 receptors. So GLUT4 receptors are insulin sensitive. But oncology cancer receptors are GLUT1. Myocardium is GLUT4. This is mainly for the use of postgraduates who need to routine standard question asked during all the exams. Another thing is Gallium Scan. As I told you already, Gallium PSMA mainly for prostate and DOTA for neuroendocrine tumors. So this is our mission, which cross-sectional view. The first image will show the CT component, routine CT component, and behind part is the PET component. Both integrated and so the depth of the bore will be more. So you can see that 234.3 kTps, kilo counts per second. This much amount of radiation is coming out from the patient body. So now the newer technologies, these light burst detectors, and this is the container which we used mainly for the transport for the radioactive material. FTG is getting transported in this containers like this, which is fully lead sheeted. And this is our radiopharmacy lab. Once we receive the medicine from our Bangalore or cyclotron, then we adjust according to the patient's availability, dilute it, then we start injecting the patient. And this is the patient will be sitting there. You can see all the lead blocks here, and just arm is only stretched out, and the technologist who is out other side of sitting other side will inject and do the procedure. So the other conventional technologies, you can see what is the recent advances in PET is now a lot of various softwares. Initial school of thought was like if you know 16 slice CT, we give a good image. But what about the other slice, like higher the slice, 64 slice, 256 slice CTs will give good quality of images. So initially, to improve the detection of cancers, PET CT scan was there with 256 CT. But once what happens is the drawback is more of the radiation is given to the patient. Already PET itself will give more of radiation, and the CT component will accept more radiation. So now the concept slowly is getting reversed. A lot of software has come. One of them is Q-Killer, which we are having. So what is this software? It gives us image quality of 64 slice CT, but the machine is only 16 slice. So overall radiation to the patient is very less. So oncology applications is mainly early detection, staging, and once you have to assess the treatment response and to detect disease progression and any plans and modification of treatment plans and to identification of the disease recurrence. So this is a few pictures where how the PET is used when CT scan, which is very hard to see, which is very obviously looked on the CT scan, a lesion in the tongue and the neck node and another submediastinal node, which is very clearly seen. And this is poorly with the tumor margins, which is very clearly seen, which is mainly used. This tumor margin clearly demarcation is mainly used for radiotherapy purpose. And these are the scans, pre-treatment and post-treatment scans. Generally, we can see CT scan will be the routine imaging, and PET scan, proper PET scan imaging will be these grainy images, which you can see only on one hot spot is seen. These two get mixed and gives a clear picture. So what we have go with these values, standardized uptake value more than 2.5 is significant. Nowadays it is slowly increasing. So up to 3.5, there are chances of inflammation is also going on. So the cutoff value has not yet derived, but less than 4 is the current concept. Then based on mainly the formula it is derived. But how is it derived? Concentration that takes place activity in a particular location, which is divided by the injected radioactivity upon body weight or surface area. Another non-oncological applications in PET scan is this myocardial viability, which is called as hibernating myocardium, and neurology applications are dementia which is mild impairment, and to detect epileptic focus. And these are the images where we can see this is the defect rest technician scan, which is done in the gamma camera showing a defect, but FDG PET is showing the uptake. This shows the hibernating myocardium, that is viable myocardium. If both are there, this is an example, classical example of scarred myocardium, where you can't see the donut, half of only you can see the half, another anterior and septal wall is gone. And normal brain imaging with an epileptic focus showing hypoperfusion. Same again in normal with Alzheimer's showing the hypoperfusion of the brain. And here it is a Doppler scan showing normal. What is the pre-treatment? Also on post-treatment, you can see the uptake is getting improved. And depression patients, which is post-treatment, it is getting recovery phase. And in case of brain trauma, you can see the hypoperfusion of the brain. And another concept is PET-CT-based radiotherapy planning is also coming up, where we need to have few changes, like we need to have flat couch and lasers are used. And already Dr. Karthikesh told you, these are the mass, which is showing, you can see the isodose curves, and you can see tumor is clearly delineated, and 100% isodose is completely encircling the tumor. And then another example of lung cancer, where multiple beams are placed, and you can see the 100% isodose curve completely covering the tumor with no miss. Another thing is F18 PET scan, F18 PET bone scan, where you have only sodium fluoride, only F18 molecule is used, which is very highly sensitive in detecting the lytic lesions. You can see this F18 bone scan. Other uses are in GIST, process infection, PUO, vasculitis, diabetic foot infection, and in rheumatoid arthritis. Coming to nuclear therapy, where we have low dose and high dose. Low dose is done as an OP procedure, mainly with 4 hours fasting and iodine use used for hyperthyroidism, toxic therapy, and for bone pain palliation, P32, samarium, strontium, or glam. And for high dose, we have a separate isolation room with a fume and lead shield, mainly used for iodine CA thyroid post-op. With any residue is there, the ablation is there. And in lutetium therapy is used for palliation in case of neuroendocrine and prostatic cancer. This is our special nuclear therapy ward where the entry is totally restricted and a separate nursing station. And we have a delayed tank, 2 delayed tanks, and our fume hood. Because of why we use fume hood? Because toxic fumes will be coming out of iodine. So this should not be getting inhaled. So we have to have a proper fume hood. And this is the patient, and you can see the lead block where we stand on the other side of this and talk to the patients. And these are the logos. Probably everybody will be aware. We need in these first top 3. If we get less strength, we get worried. We need more of the strength in top 3, but in below radiation, the logo, we need to keep this under less. So actually, the radiation people think, but in reality, it is not like this. Radiation is a friend, and we employ this proper TDS, time, distance, and shielding, spending less time, keeping adequate distance, and using appropriate shielding. So we make it radiation, how far it can be useful for the patient. So radiation, think radiation as your friend. Of course, it is a scary stuff. You can't see, smell, or touch it. Hope I have given you a small gist about the nuclear medicine department. Probably in next talk, I will cover what are all the interesting cases we come across in future. Thank you.
Thank you, Dr. Nagesh. Any questions from the audience?
Good evening, sir. Dr. Karthika here. It's not a question. Yes, Sajan, thank you that you gave information to all that our management has approved tomotherapy. And from on behalf of Radiotherapy Department, we are also very happy to know about this because it's approved by the management. We thank the management for the same. And for tomotherapy, as you said, yes, I understand from what you told. Maybe just to add few points. The peripheral dose or the marrow dose is very less with Tomo, and it's a wonderful machine, especially for total body irradiation. What we do for bone marrow transplant, the preparation of the patient before BMI, and for craniospinal irradiation. We don't have another machine which can generate a continuous treatment like a Tomo machine. Of course, any technology will come with some negative points as well. One thing is it has only one energy, so the CBCTs we take in Tomo machine will be in 3 MV CTs. So the clarity of CBCT may be little less, and the treatment time will be little longer. In Infinity, like what we have the present machines, we treat even IMRT patients like in VMAT, it's only 2 minutes or 3 minutes, the whole treatment will be over. But it's not the same with Tomo. Tomo, for a smaller field, it takes around 6 minutes to 10 minutes. But for longer field like TBI, we have seen even 40 minutes of treatment. So that's the only thing. But otherwise, it's an amazing machine. And I really thank the management for approving this machine. Thank you so much.
Thank you, Dr. Karthika. And participants, any clarifications, questions?
Surgeon, it's just a suggestion. You could have put some few more points about robotics and oncology.
Yes, it's all evolving. Yes, it is coming in. Thing is, it's all concept is minimally invasive. That's the idea. Between robotics and laparoscope, there is no difference. Again, it has got its learning curve, and sometimes we should choose the cases. Everything cannot be done robotically or minimally invasive.
Yes,
Sometimes we
yes,
do,
surgeon.
even today, we come across patients who should not, with the wrong indication, patients who should not have been done or being managed into minimally invasive method for sake of doing it minimally invasive, wherein the oncology principles or the outcome is ignored or compromised. So it should be chosen, only appropriate choose cases should be this thing. It has its own advantages like uh, the early recovery, less pain, no wound complications, no hernias. But these are the most important of all these things is the cure should not be compromised for sake of these. So
True, surgeon. So whenever you go for technology, it is like case selection is the important key, right?
yeah.
Yeah, that's the take home, I think. Thank you, surgeon. It's really a large topic, and you have done justice to it. It's been too elaborate. Advances in whole of oncology is like in finishing in 30 minutes is too short a time for you.
I might have missed a few advances, but still it's happening in almost all fields. So
If there are no other questions and discussion, then I thank Dr. Karthikesh and Dr. Nageshwar Raj for sparing their time and accepting our invitation to address all the participants from the city of Coimbatore and giving a wonderful lectures. And I thank once again all the doctors from Sri Ramakrishna Hospital and also from outside the hospital and all the consultants from inside and outside. I thank all of you once again. Thank you very much.
thank you very much, sir. Thank you very much for the opportunity.
Thank you, Karthikesh. Murali?
Sir, thank you, sir.
We'll wind up.
Yes, sir. Yes, sir. Thank you, sir.